on our history, our successes that we had. So this presentation basically will focus on how can we build from there. And as we all know that today's environment where, how can we make sure that we're not really just cutting all our expenses and thus jeopardizing our ability to deal with whatever the challenges that's coming our path. So this is about how can we look at our capabilities, each of us, and as a NISARC as a whole, we have huge strengths in many areas. And as a single corporate entity, how can we ensure that we are stronger together? I want to share with you a little bit about the organizational capabilities from this article from Harvard Business Review. It really talks about how we can look at our organizational core competencies from a technical perspective and the capabilities from a social perspective. And this compares from how individual staff capabilities as well as an organization as a whole. And really talks about how to build from there and using those core competencies, develop the business models that essentially capitalize on our core competencies. So it's a little bit different than simply a traditional norm on collaboration initiatives or cooperations that oftentimes talk about how we can achieve efficiencies. This is looking more from an angle of the main focus is to build capabilities, and efficiencies oftentimes can come along with it by building the model, the business model that is coming from the core competencies of organization. So with that, I'm going to move. We'll have Chris talk a little bit about how the Mid-Hudson Collaborative have looked at it from the angle of building from the strength, building from capabilities. So Chris.
Hi. Okay, are we ready?
Yep.
Okay, you can, move off my name. Thank you. We actually started with 5 chapters, and that included Dutchess, Putnam, Sullivan, Orange, and Ulster, Greene. And we, as a group, we sort of knew each other because we're from the Southeast region, and we began to talk about how we might be able to do some things together. Generally, our initiation of this came about through a concern that we wouldn't be able to do this alone. And so we began talking as a group on how we might be able to do things together to migrate to managed care, and it was initially probably a survival sort of discussion that we were having. So you can scoot to the next slide. We really did begin talking prior to this, but around August 2012, we recognized that NISARC at that time was discussing a lot of things relative to managed care, and had begun to talk a lot about collaboration and how that could strengthen organizations, and in particular how we could support each other and create capacity which could be measured and then also used again and replicated in other places. So we decided as a group that we were going to just begin talking about the kinds of things that we'd be able to do. And this led to, it didn't flow in a step-by-step process. We spent a lot of time together, and most of that time was in the evening. We had dinners together. We had informal meetings together where, and we were very open and upfront about what our agendas were and what our agendas were not. Some people, began by talking about the possibility of a merger, and then others of us who weren't there yet said, I'm not ready to discuss that. But we were all very open and direct with each other about what our agendas were in the development of this collaboration, which we still define it as. But at the heart of it was our understanding that with managed care, we were going to need to be doing things together, because as single units, we knew that we would not be able to get through this by ourselves. So given that we had a lot of that, then we began to think about the components that, and we jokingly refer to it as putting them in the container, the things that we might do together. And we recognized early on that in order to do things together, we needed to begin to include in our group meetings our key leadership staff. Because if we didn't do that, there was the risk of people feeling like there was an agenda going on they weren't aware of, and we recognized, all of us, that we needed our key leadership staff to help us do this, that no one person could do this alone. So we created a process where it included not just executive directors, but key leadership staff from all 5 chapters. We did lots of group learning together. We invited Peggy Terhune to come to our region, and Peggy Terhune is an executive director in North Carolina who knows a great deal about managed care, and she came and spoke to us, and we included our CFOs and our operations directors and everybody in that discussion as 5 chapters. So we learned together, and that, I think, was very helpful, because that everybody was developing the same mindset about what we needed to do together and where we needed to go. So because of all the learning that we did together, it became pretty clear that if we worked together, we could probably generate some new outcomes as a group that individually we couldn't pull off. And that led us to some discussions about what a real collaboration was. And I think most chapters recognize and have the relationship where we share stories and we tell each other about the problems that we have, and we commiserate together, and we maybe even once in a while help each other. But we recognize that if we were going to be successful in this collaboration, that we needed to really, really acknowledge that we were going to share resources, we were going to share risks, responsibilities, and ultimately rewards. And that took a lot of discussion to get us. These 5 little bullets here was probably a year-long process of us talking and learning together about what collaboration was and what partnership really meant. So you can go to the next slide, please. And we got to this point. We got to this point with all 5 chapters in our leadership teams, where we recognized that we had a collective vision of what we wanted that went beyond our county boundaries. We recognized that it was healthy and important to share what we were good at, what we weren't good at, and what we were struggling with. And in order to do that, we needed to really respect each other, and we needed to create an environment where there were no hidden agendas and we could trust each other with the information that we were sharing. Our intent really, in a nutshell, for this collaborative process was to, in line with everything we're hearing about managed care, was to really streamline what we do. And recognize that there was probably some duplication that we could eliminate through the process. And perhaps most importantly, we were each at different levels with our electronic and technology systems. And we recognized that that was a flaw for some of us, and there was more strength in some of the other organizations than in others. So we recognized that if we could do that together, that we could be stronger as a unit. So that was the other part of our discussion. And then we ultimately believed that if we work together, that the quality of the support we provide to the individuals we serve would be healthier and would be measurable, because we would measure ourselves against each other, and we could create our own outcomes that would be tied to the quality of the support we provide. Next slide. I think the most important activity that we undertook was our accreditation process with 5 chapters. And initially, we intended that we were going to get a regional accreditation, but quickly learned that in order to get a regional accreditation, we had to have the exact same policies and the exact same procedures in all of our 5 chapters. And so rather than undertake that piece, what the 5 chapters agreed on was that we would have the same policies relative to issues around basic assurances and self-assessment, but that we would allow, we would recognize that certain organizations have particular needs and their protocols could be adapted to meet their needs. So even though we recognized we were going for separate accreditations, we continued to work together and learn together. We created an executive lead. We identified who the executive lead would be for this initiative. And then we as a group held joint informational meetings with all of the CQL staff that came. We did this as a region as opposed to individual meetings in our counties. We had a session for the 5 chapters to have our trainers certified. So they all trained together, they got to know each other very well, and they continue to work together actually. And that has been very helpful in that we share trainers within the region, and we were actually doing that before CQL told NYSARC that we could, because our group, you know, had already created this and they were fine with what we were doing the way we developed it. We also worked together getting through that self-assessment piece. We had work groups for there's 8, 9 factors for the accreditation process. And so we had 9 work groups, one for each factor, and they were headed up by an individual from one of the 5 chapters who was the facilitator and comprised of representatives of all the chapters. We had one executive director who was assigned to each factor work group just to ensure that everything was being communicated and we were in the loop. And the routine meetings were held. And during those meetings, it was the focus of that group to not just share information, but share their processes and policies and really take a critical look at, are we doing that? Or if you're doing that, how are you doing that? And maybe you can help us. So it was a real learning environment that occurred between all of these 5 chapters, and very healthy process. The end result was all of the chapters were accredited separately. We had a joint celebration at the end of that and brought everybody together. And at that time, we shared all of our individual chapter outcomes and goals and projects for our accreditation process. The good news is that this collaboration continues because our trainers now work together to get recertified every year. They organize that themselves and they do that. And the recertification of them, the location of that is hopped around to each of the 5 different chapters. And leadership and the management staff of all 5 chapters have developed really healthy cooperative relationships in terms of how we continue to move forward. So that has been an enormous benefit starting out that process because we learned from each other. Next slide. I guess probably IT I would say, has taken off in the collaborative sense more successfully than we anticipated. Our intention initially was to develop a regional sort of approach to this, and all of that was rooted in our issues around managed care. We knew we needed to have electronic files. We knew we needed a lot, and the capacity for each of the chapters was different. And for those chapters, and Dutchess was one of them, I quickly recognized that it would be less costly for our chapter to participate in a regional IT department than it would for me to build my own IT department in and of itself. And I will tell you that, yes, that has been my experience. We have a benefit of and a number of trained, skilled people, each who have their own strength, and it has really benefited. Now, what has happened with our IT department, our collaborative, and I think this is really, really important. We started out with 5 chapters, and one chapter said, I don't really think this is going to work for me. I'd rather do this. And that was fine. So they did not join the collaborative. For a year, we had 4 chapters in the collaborative, and at the end of that year, one of the other chapters said, this isn't working for me. I'd like to go another way. And that was okay. So where we are this year is we have 3 chapters in the IT collaborative. And that seems to be working well. But the important part of that is, if you could maybe go to the next slide. This is everything that Dutchess, Putnam, and Ulster Greene have been able to accomplish in 2015. We have 2 chapters that are working on rolling out their electronic files, and we're doing that with the support of the other chap. Dutchess and Putnam are rolling them out. Ulster Greene has had TheraP, so their staff at Ulster Greene are working with both staff of Dutchess and Putnam to roll that out in our chapters in a thoughtful way, and that's working well. We integrated all of our networks into one main data center, and in thinking about disaster readiness, and that was a huge process, but one that we thought was necessary, and we all breathe easier at night knowing that we've got a disaster readiness situation and we're safe. So these are just a few of the bullets that we've been able to do collaboratively through the IT collaboration. Next slide. But as I was saying prior to this slide, each chapter made their own choices based on what their needs were, their capacities, and their priorities. And so when the 2 chapters that initially started said, this isn't working for me, what was really important was for that to be okay and for us to say, no harm, no foul. We didn't try to force a square peg into a round hole. And we recognize that each organization has their own individual identity. They have their own systems that may not fit nicely into something that you're working. And I think that is an important part of our collaboration, is that just because we, the 5 chapters, decided that we were going to work on collaborative activities, it didn't mean that absolutely everything that we did had to be done together from here on in. And I think that's one of the reasons that we're feeling that this has been fairly successful and a non-threatening sort of way to, and an organic way to approach collaboration. And as you can see from the past slide, we got a lot accomplished for the 3 organizations that are in the collaborative. So that was our intent, and that's what we got. And so we made opting out of an opportunity not personal, which I think is really, really important. So next slide. So to date, as I said, individual chapters make their own choices about the levels of participation that they feel fit them. And the result of our collaborative with these 5 chapters that began in August 2012, we have 3 chapters, as I said, in the IT collaborative. Dutchess and Putnam are sharing a CFO, which is working very well. Putnam and Sullivan are sharing a clinic director, which again is also working very well. We have 5 chapters that share CQL certified trainers and collaborate throughout the year. And the other thing that I think is worth mentioning is there's a periodic, I'll say, blurring of our county boundaries. And I think that's something that we're going to have to consider as we move forward. For instance, an example, the Arc of Dutchess was given an opportunity by a company that's housed in Dutchess County to create a work location. They couldn't do it in Dutchess County, but they have a site in Ulster County, and wanted us to come over there with have one of our individuals work there. Rather than give that up, I called Ulster Greene and spoke with the executive director and said, do you have a problem with that if we do that? And of course he said, no, that's fine. And it may not end up working in the future, might be too far of a commute, but we both agreed that that was okay for that individual to have that job in that area. I know that Ulster has asked if they could do some transportation services in northern Dutchess, and I have no problem with that because it's just across the river. So I think the territorial sort of boundaries that we've set up in the past, we have to start thinking about, does that really make sense? And maybe stop looking at ourselves as competitors and start looking at ourselves as collaborators, because there's plenty of work. And to be honest with you, the issue of efficiency, I know when we started this collaboration, our thought was we wanted to be very efficient. And that meant for some people not spending more money than they were spending now. But the reality is, for me, I am spending more money, but in order for me to be productive, I would have had to spend that anyway, and I'm spending less because I'm doing it collaboratively. So that's our thought. Thanks.
Okay, Sadie would be the next panelist.
All right. You can go right to the next slide. So I'm hailing from the North Country. Up here we represent 4 chapters in 5 counties. The counties served by our collaborative efforts are Franklin, Essex, Clinton, Hamilton, and St. Lawrence. So here's a little bit of the demographics of the North Country. I'm not going to spend a lot of time on that. You can go to the next slide. The North Country MSO represents those 4 chapters in 5 counties. The MSO itself has 88 employees. We have almost a $6 million budget. Next slide. And that's the geographic area we cover. So go to the next slide. The North Country MSO is a formal collaboration by the 4 chapters in the North Country. This is our mission statement. It's probably the longest mission statement in the world, but basically it says that we came together to try to find some efficiencies in the administrative side of things so that the executive directors of the 4 chapters could concentrate their efforts on the provision of the operational side and the supports to people receiving services, and that we could offload all the administrative headaches and burdens onto somebody else. So, that was why we created the North Country MSO. The next slide, please. So, this was November of 2011 that we first got together and started talking about what were some ways that we could find some efficiencies I think around that time we were looking at the governor saying that folks had to restrict their administrative budgets to something that was going to end up being pretty unreasonable. So we thought, let's figure out what areas we could try to collaborate on and save some money. So these were the 5 areas that we looked at. We agreed that we probably could find some duplication of effort there and kind of streamline some processes. So we worked with state office at Nassau to try to develop, a formal legal entity to put this stuff into. And so we did form, the North Country MSO. It's a legal corporation. It's a subsidiary of Nassau. Nassau is the sole owner of the organization. We have a formal board of directors that is comprised of the executive director and a board member from each of the 4 chapters, along with 2 folks who represent NYSARC. So we do have a board structure that governs this MSO. We have, we're working on a strategic plan for going forward in these 5 areas. So let's go right to my last slide, and I'll spend all my time talking about that. So why the formal versus the informal collaboration? We kind of felt like it would benefit us if we had a formal relationship with each other, so that we were ensured that each of us had buy-in and that we couldn't very easily say, you know what, this is way too much work, or this isn't working for me and I'm going to, take my ball and go home. We knew right at that first meeting in November of 2011 that we all shared the same philosophy about the 5 areas of function that the MSO was going to enter into. We already had some common platforms. We were all using Great Plains. We all agreed to use the same auditor. We were all using the personal outcome measures for CQL. So we decided that we would just work with these areas. We figured that the staffing, even though we represent a large geographic area, we knew that there was a way that we could bring those people into one unit and have them function as a team. A lot of medical offices have their billing done by some, external party. They contract that out. So we looked at, what are these things that we could contract back to the chapters, and potentially at some point down the road, contract, sell those services to other organizations in the state. One of which that would be like the easiest thing in the world to do is Medicaid billing. That's pretty standard. We all have the same platform to be able to do the Medicaid billing, and we could do that for an organization that wanted to, offload that. A couple of the areas that we really made some great strides in early on was the IT. We try to look at some of the things that are the easiest things to kind of coordinate with one another, and IT was one of them. Of the 4 chapters, my chapter was the only chapter that didn't have any IT staff. We have a contract with an external firm to provide that remote support to us. So it was pretty easy to talk to those staff that are now in the MSO that used to belong to the other 3 chapters to try to figure out what can we do to try to, bring my chapter into the fold, get rid of that external contract, have the folks that are in the MSO provide that level of remote desktop service to us. So we're working on that. We purchased a server. All of the agency's records are on a main server. We've got a disaster recovery plan that's been established by IT. In terms of finance, I think the hardest thing to do was all 4 chapters got together and decided we needed to standardize the chart of accounts. So that took a while, but we did that. We tried to figure out how to standardize all of the operations among the 4 chapters, even though the MSO employees are still working physically at the chapter. They're not together under one roof. if we figured if we standardized all of the platforms and processes, then if somebody was hit by a bus and was out for 6 months, somebody else from somewhere in the MSO, maybe not at that location, could pick up and take over those services, and we wouldn't have to hire necessarily a temp, and it wouldn't leave the chapter in the lurch trying to figure out how you were going to do some of these processes without the staff. So we've got folks cross-training, we've got standardized processes, reaction to attrition. We're beginning the discussions now about what happens when you have some long-term department heads, whether it's in the area of finance or human resources or IT. If you've got those department heads that are getting close to retirement, you know, what are we going to do to replace those folks as they leave? So some of the discussions we're having now is making plans for you know, succession planning for those positions, and trying to figure out, okay, so if we have, you know, 4 HR directors right now at 4 different chapters and one of them retires, is there a way that we can not replace that HR director, end up with 3 HR directors, and be able to have the capacity to whittle that down, and maybe over the next, you know, decade get down to 1 HR director and a bunch of support people, and do that in each of the functional areas. We may not get down to 1, but we could get down to 2 of those department heads serving the 4 chapters. So those are areas we're looking at. We're trying to figure out, you know, who's got the best practices in terms of quality assurance, developing some tools that are common. And then over time, we will see savings. Right now, you know, we just completed our first full year of operation formally. We went live January 1st of 2015. So we're, you know, kind of doing a look back and a look forward right now to see where we're at. We figure probably in the next couple of years we'll see some significant savings that can be, you know, reinvested back to the chapter as we, you know, whittle down the administrative burden that we have. We also, you know, when you're looking forward at managed care, because we're not quite sure what that's looking like, but you all probably saw the email that came out from Tanya about the IPAs and the ACOs, and so I don't know if this formal structure of an MSO will have a role in managed care going forward. You know, right now we're providing supports to the chapters. Is there a conduit? Is there a way it can be a conduit for those chapters to the managed care organizations? I don't know. That's, you know, certainly something that we're going to be, you know, looking at and trying to figure out. So that's kind of where we're at. I think I hit all of our all of our points, but the reason that we decided to go with just, you know, kind of collaborating on the administrative side of things was that we recognize that each of the 4 chapters culturally are a little bit different from each other, and we don't want to, like, make everybody be, you know, singing kumbaya about operations. This method allows each of the agencies to continue their own culture in terms of their operations and just divest themselves of the administrative burden. So I think that pretty much covers it in 10 minutes. Thank you.
Okay, you're back up.
Okay. Before we go to our next panelist, I wanted to give a little bit reminder that if you have any questions, please type in the question box. And at the end of the presentation, we will open it up to all the panelists so they can answer any questions that you might have.
Go. All right, Stanfort should be live.
Okay, Stanford, you're on.
Thank you. As we looked here at Nassau at building organizational capacity, it was important to us that we kept a clear focus in mind, which was basically a goal to continue the provision of high-quality services and supports to people with developmental disabilities served by our chapter first and the community in general. So for us, there was a sense of personal corporate responsibility for the continuation of our mission, which is certainly threatened by rate rationalization, other cuts, and a slew of other things that are clearly headed in our direction. In terms of aligning with others who have a mission which aligns with our need, we found that working with other not-for-profit providers, those who can relate to our missions like hospitals, clinical practices, builders, developers, foundations, and our need to be able to show how our mission is more global and how we impact the corporate community certainly could have an impact on how they view us and see us as partners as we move forward in building capacity. Our capacity, as we understand it, does not exist primarily among other not-for-profit providers, but the community in general. The area of expertise being different was critical for us because we, in building organizational capacity, we're really looking for partners who brought something to the table that we did not possess. So it did not matter that their expertise might be different as long as there was something to be gained to support the primary mission of the chapter. And we're also developing partnerships to look at a number of different areas where we have some weaknesses, and they're partners that we are working with to identify some areas where we can possibly gain some additional strength and performance. One area for us is employee recruitment and retention. We've been looking at metrics that basically put a ton of data, millions of bits of data, through an algorithmic process to really help us identify candidates who fit with the highest probability of success in a selected position. And that data would be statistically significant. Again, that's a major area of concern and weakness for us as we move forward, so it's important that we come up with different methods to indeed impact something that is central to our mission, and that's having the ability to identify good staff, strong staff, and to be able to forecast the potential longevity they might have with us and their ability to also move up the career ladder. We're also working with current business partners to expand social entrepreneurship, to address declining revenues, and that includes some of our major vendors, in addition to working with research and development specialists to determine our best fit and what will work in Nassau County as we move forward. We're also working with our community development and economic development offices, federal and private enterprises as well, to create new residential and other opportunities to basically engage in mission fulfillment as well. As it relates to chapter work, there have been ongoing collaborations going back now for years with Suffolk HRC as it relates to eWorks, which is a recycling business that was started a number of years ago to employ people with disabilities, which is now in a number of other areas throughout the state, as well as IT services. Suffolk shares IT services with us, and there have been ongoing discussions between a subcommittee of both of our boards for a couple of years now, and that's continuing to discuss future collaboration as there are changes in the industry. You can move forward to the next slide. In terms of a managed care environment, we've all been in service to death on managed care, and there were some things that stood out for me that were critical to HRC Nassau, and as we get ready to launch the marketing for PHP so that families can enroll in the FIDA on March 1, and the FIDA will be starting on April 1, there were just some key components that we found to be essential. One is understanding the real costs to provide a service, which could be very different immensely from our fee-for-service structure that's currently in place now. So it's important that a chapter be able to determine exactly by unit of service what it takes to provide a support to an individual in whatever manner that you serve them. That's critically important. Excellent assessment tools to determine baseline data and changing acuity levels so that you're not relying purely upon a managed care organization to do that for you, but that you're in a position to know through very clear metrics what it costs to provide a unit of service to anyone. Cost containment based on required assessed needs, which differs greatly from what perhaps we have been traditionally providing to individuals. So it's really important that there is a method by which we can determine what an individual really needs versus what they want or what their family might like for them to have, but real needs based on that agency's ability to provide services within a cost-contained environment. Measurable quality metrics is, again, an essential component. You have to be able to measure outcomes, and if we truly do move towards value-based payments, it will be critical that we be able to measure quality in a very dynamic, fluid fashion. Outcomes must be driven by design. They can't in any way be accidental. It's important that we plan outcomes and that we put into place the necessary level of intervention to achieve that outcome in the most effective, efficient way possible. Electronic health records, electronic medical records technology is essential and a basic, which by now most chapters have that in place. The ability to offer flexible day and work opportunities, again, we may find to be a more cost-effective alternative for people who don't seek the routine and at the same time may deliver much better outcomes for folks as well. So seeking ways to offer flexible day and work opportunities for folks is something that is ongoing but should start as soon as possible. Staff training is critical to ensure uniformity. We found that making sure that all staff were on board as it relates to the tracking of services, the provision of high quality supports, and just an ongoing understanding of what is required in a managed care environment and how to document and track your work in that environment is a critical concern, especially with staff turnover, and you can't really allow for a day that a person works that they don't clearly understand how their role impacts data and costs as it relates to service provision. So staff training is an ongoing critical need, and in addition to that, overlaying a strong compliance and quality assurance component is also necessary and critical as well. Preventive services we can't speak enough about also as they are indeed critical to saving dollars and improving the quality of lives for the folks that we support. So preventive care, strong care coordination across the board, ensuring that we are providing good checks and balances, not duplicating services, not duplicating tests, and only providing to people the level of services that is needed for their growth and habilitative enhancement is what's necessary. Life planning tools, care coordination, critical aspect. It's very important that there be ongoing synergy between the staff who work in the agency, the care coordinators who work for the managed care company, that they're constantly on the same page, that there's ongoing communication so that indeed the needs of the folks that we support are met while at the same time guaranteeing that they're going to be supported by the plans that are being executed and paid for through the insurance company. So the life planning tools and the engagement of the individual and the family in designing the care plan is, again, essential. And then I'd like to just stress to close out that volume is an important aspect in a managed care environment. So it certainly helps to have volume, and to hear about the variety of collaborations that are existing is certainly a direction that helps to ensure that we will have the mass necessary to create the level of financial support that will be needed to meet the needs of the total population. Collaboration maximizes the overall potential success because as much as we can broaden the number of folks who are receiving services, the better the opportunity is that we'll be able to meet a variety of needs within that particular paradigm. And that's it.
Jack, right? You're on.
Jack, you're on now.
Okay, we're ready to go, Bakar?
Yep.
Okay. Let me start out by saying I apologize to everybody here. I didn't have time to put slides together, so I'm going to be really boring. I was in Florida enjoying myself. So just to start off, before I talk about the experience of the expansion of 10 clinic satellites in 5 upstate counties, let me give you a little bit of a backstory here on why we thought that we might be able to go this route and help support our sister chapters. Back in 2000, when Madison chapter merged with the Cortland chapter, one of the issues that became really clear right out of the gate was that the Cortland chapter was lacking a lot of clinical supports, which was creating a lot of quality difficulties, a lot of program certification issues, and just a lot of things that couldn't be addressed without clinical supports. So one of the things that we did right out of the gate was we asked OPWDD to allow us to open a clinic satellite in Cortland County. We did that, and just so people are familiar with the distance from our main office in Madison to the main site in Cortland is about 65 miles one way, 130 miles round trip. So it's not right around the corner. That presented a number of challenges for us with software expansion, hiring clinicians, finding the right mix. Ultimately, we expanded that whole idea back in 2000 to not only help support Madison and Cortland ARC, but we also included the J.M. Murray Center, and we opened up a satellite at the J.M. Murray Center in Cortland, which is just a little bit further away than the Cortland office or the Cortland chapter. So we actually began running 2 clinic satellites a significant distance away from our main site here in Madison County. At that point, distance really didn't become an issue because of the software packages that we tried and failed, and I'm going to be very honest with folks that we've been operating an Article 16 clinic since 1993. Not until about 1.5 years ago did we actually figure out how to put all the pieces together to actually make it a break-even profitable venture. Let's fast forward to today. With that backdrop, we've had experience operating long-distance clinic satellites for the past 16 years. We also have, in Madison County alone, we operate 3 additional satellites for the convenience of our families and for the convenience of the folks trying to get to their clinic appointments. So we essentially have 5 satellites in total, along with our main site, as we speak right now at this point. So satelliting was not a new concept to Madison Cortland ARC when this was put out there. And I told Bakar I was going to be really honest with folks when I said this. I said no 3 times to the clinic expansion up front because I had just gotten our act together and I wanted a little time to experience the success, but recognizing that OPWDD was really going to put a cramp on many of the providers, including our chapter's ability to be able to provide direct clinic support services. I saw the need that had to be filled there. And frankly, we talk about the clinic as being, we here at Madison talk about the clinic as being a linchpin of support for all of the programs that we're providing supports to. And I use the example time and again that the people that I'm backfilling in our residential program, we have 45 supervised beds in Cortland, we have 55 supervised beds in Madison, we have 12 family care homes, and we have an freestanding respite center that we also provide clinical supports to, and we operate that 7 days a week. The idea of us being able to backfill vacancies in our residential program and our day programs without clinical supports and taking people off of the priority 1 wait list would be a challenge at the very least with a clinic. Without a clinic, I can't imagine what that challenge would be. And when Stanford was talking about volume and critical mass, and that's my word for volume is critical mass, the idea that you can go for extended periods of time in your residential or your day program without backfilling those vacancies, and it's not going to affect you financially, or it's not going to affect that individual or that family member by not being able to get that service, is ludicrous to think that you're not going to be able to do that without the proper clinical supports to be able to deal with the priority 1 referrals that are going to be coming to you both residentially as well as day program wise. So with that backdrop, we did see the need, and we initially met with all of the partners. We had a meeting here in Madison. We had Oswego, Oneida Lewis, Herkimer, and Shenango attended the initial meeting, and essentially we had to lay our cards on the table just like everybody else has said and be very frank about how this was going to work, at least for the partners as well as Madison Cortland ARC. There was a lot of hurdles to work through, not the least of which was, who's going to be the controlling entity in this. And I take a position, and I know there's a lot of other thoughts on this, but I take the position that if you're the licensing entity and you're holding that license and you're doing the billing, you're holding all of the risk associated with this clinic expansion. So what we needed to do is we needed to agree that if Madison Cortland was going to come out of the gate as the primary risk holder here, then we wanted the employees to be, or the clinicians to be employees of the Arc of Madison Cortland. That said, there really wasn't a lot of clinicians between the 4 chapters that would really need to move from the employment of that other chapter over to our employment. What we found was that we're going to have to hire out of the box brand new clinicians to come in to meet the identified need. And I got to give a lot of credit to all 4 chapters who did not have a lot of experience in identifying need. They worked really, really well with our clinic director and our treatment coordinator and our operations director in identifying the actual needs of what the chapter, the families, and the individuals needed. And we were able to come out with a fairly good needs assessment. That had to be turned around very quickly, given the time frames of the CON. Once we got that out of the way, and once we got the clinician supervision out of the way, then we needed to identify what actual physical space at each one of the chapters was going to be the most convenient, not just for the chapter, but what was going to be the most convenient for the families and the population that we were going to be supporting. And then the last thing that we had to look at is one of the things that we learned at Madison Cortland is when we opened our first clinic back in 1993, and I'm just going to use an arbitrary number here to make it easy for folks. If we had 100 people enrolled in the clinic, 90 of those 100 people are what I would call your captured population, meaning there's the people that are in your day hab program, they're the people that are in your residential program or your workshop or wherever they may be in a program type of entity. And 10 of those people came from the community who weren't tied to any physical program that you provided. Now today, in 2016, that whole scenario has turned absolutely 180. What we find now is that probably about 75 to 80% of everybody that we serve currently, Madison Cortland I'm talking about only, are all community-based people who have no tie to a physical program at Madison Cortland ARC, and the other 20% are the quote-unquote captured population. So what we needed to work through with that is to plan that once you open the clinic, once the community services boards and once the community finds out that this support is available, and also by regulation you need to make that service available to the community, we needed to plan on additional capacity to be able to serve when that turned from the captured population to the community population. So that was also something that we had to work through more so on our end to look at what the historical trend was and how that started turning from the captured population to the community-based population. Essentially, what we've been able to do, and again, I give tons of credit to. I know what a struggle it was for Madison Cortland ARC to get the clinic off of the ground. What we learned and what we were extremely weak at over the course of the last, and I'm going to say probably 10 years, was we were great at billing Medicaid, and we were great at billing Medicare, and we were great at doing the crossover claims between Medicare and Medicaid. And we kind of, I don't want to say we ignored the third-party insurance, but it was really complicated and there were so few of them. Those claims became sort of a cost of doing business. We didn't really worry about them too much. In the last 5 years, that's not the case. More and more people are coming to us with third-party insurance. Probably 15% of our total population, roughly, if you wanted to put that in claims terms, probably between $200,000 and $280,000 a year in revenue if you don't figure out a way to collect that. So what we did was we found a company externally to come in, and we contracted with this company called Medcare. They're out of New Hartford, New York. And what they did was they came in and they credentialed our organization and all of our clinicians with all of the third-party insurers. So now we have a mechanism and a system through our software package, along with the help of Medcare, to do crossover claims, and this gets to the point of being able to maximize the revenue and being able to maximize everything that we have in front of us to be able to keep the clinic financially viable going forward. This is going to be a huge challenge for us because as we open each one of the clinic satellites in the 10 counties, each satellite is going to have to be credentialed by each one of the third-party insurers. And as it stands right now, we're dealing with approximately 16 different third-party insurers, along with the Medicare and the Medicaid. So with that, 10 satellites are going to have to be credentialed. Each one of those clinicians is going to have to be credentialed with each one of those third-party organizations in order for us to ensure the financial viability of the organization and the clinic, but also to ensure that we have clinicians available to provide the supports associated with that. I'm going to stop there at this point, and I could go on for a long time, and we're past 5 o'clock, but I'll throw it back to you guys, Bakar, and if people have any questions, the only thing that I will end here with is this whole process with the 4 chapters. I can't imagine it going any smoother or any more cooperatively than it did. It was one of the nicest projects that I've been involved with in my 39 plus years in this organization, and I give great credit to all 4 of those chapters, and great credit to my clinic director and the people that work in our organization, because I had very little to do with it. They did all the heavy lifting. That's it.
Okay.
Okay. Thank you all the panelists for talking about their experiences, about as you can see, the main theme that's truly coming out here is that how can we ensure that we build on our capabilities, look at what is our strategic direction is, start to look at it, what are we good at, what are our core competencies, and how can we use, as you can see from the experiences of each of the panelists talking about working together, collaborating with each other as a way to help us meet our stakeholder value, um, and really build on our capabilities. And lastly, that I kind of want to end with that how willing are we to take on those opportunities that as being a part of NISOC chapters actually give us those opportunities, that are we willing to take on that. With that, if there is any other questions, we don't seem to have any questions. I want to thank all the audiences to join us for this. If you don't have any questions, okay, well, thank you, everyone. Have a good night.